Panindigan ko. Alright. May kanta pa, Mark. Anyway, so hello dears, good day, hello, and welcome to yet again another pre-recorded lecture in our class in Didactics. No? And for this lecture, we're going now to start, or going to discuss now the different disorders, okay, that may affect our kidneys, all right, and that is your renal disease, all right. So before ang lecture before this topic is of course about the different metabolic disorders, no? So kato mga phenylketonuria, mga inana, of course. And we have discussed the importance of urinalysis for those diseases. All right, so those are metabolic disorders. For this lecture, what we're going to discuss na good are the disorders that are really affecting the kidneys. Okay, could be na problema sa kidneys mismo, na problema sa glomerulus ba, sa tubules, all right? Or there could be a problem in the blood supply, ayan, or mga vascular disorders to the kidneys. All right, so muna siya to i-discuss karon. All right, so I'm sure although dili siya appeal sa inyong inyong compre, but I feel like it's incorporated na yun in the urinalysis na part sa inyong table of specifications. So ato rin siya po siyang i-discuss, and I hope you can still watch this. All right, balag medyo delayed na yun, no? So pasensya. All right, so again, this is renal disease. All right, now for kidney disorders, all right, actually disorders, any disorder yun, no, can really affect your kidneys. Okay, could be acute, meaning karon dayon ma-affected, or pwedeng chronic, no, long term. In the long run, dito pa siya ma-affected. All right, and they can produce abnormalities in your urinalysis. All right, so sa urinalysis results na to malantaw ang imuhang different abnormalities or different possible clues as to what is the disorder the patient is having. All right, and that's the importance of urinalysis. That's one of the reasons, if not the main reason, primary reason why we are performing urinalysis. It's because we can detect a lot of abnormalities, okay, not only from the kidneys but also of the whole body. All right, when we look at the different results in the urinalysis. That's why we perform urinalysis. All right. Now, for kidney diseases, mismo, the main goal or the main topic for this lecture is, of course, again, renal diseases. Your kidney diseases are divided into 4 major categories. Sa inyong notes, kay tulor akong ibutan nila, pasensya. Okay, ako na siya pang i-upload, so don't worry. Okay. So for kidney diseases, you have 4. Ayan. So we mentioned already that sa inyong notes, you have glomerular, of course. Next, you have tubular. You have also interstitial, or tubulo-interstitial, no? Interstitial or tubulo-interstitial. And the last one is vascular, all right? So, kani siyang 4 groups there kay basis sa Branzel na book. Okay, so ako na po siyang i-appeal para sure good na ma-mention na to. Okay? All right, sige. So, those are the 4 general groups of the kidney diseases or renal disease. All right. Now, initially, your renal disease or kidney disease may affect only one morphological component. However, of course, if mas mudugay ang imuhang disease, of course, mas pwedeng daghan ng ma-involve, alright? Or mas daghan ng parts sa kidney ang pwedeng ma-damage, alright? Because of their close and interrelatedness of their function and mga structures, alright? So, connected man sila. So, if kaning usa daot, alright, niya prolonged pag yun in the long run, pwede siyang spread kay connected na sila, alright? So, of course, it's expected na once the disease is chronic or long-term na siya, of course, mas intense ang pathology, mas intense ang symptoms. Okay? Alright, in a way, ganun. Alright? Sige. So those are the 4 major categories of your renal disease. Okay, so now first start with the first group, which is of course your glomerular disorders. For glomerular disorders, of course, these are diseases, kidney diseases that ang primary na problema or ang primary na naapektuhan is of course ang glomerulus, alright? Nasa pangalan na, glomerular, alright? And for glomerular disorders, majority is of immune origin, meaning immune-mediated siya. It could be that there is deposition of the immune complexes, circulating immune complexes, or mismong nireact ang antibodies na sa imong lawas against the antigens of the glomerulus or other antigens found within the glomerulus na dili jud parts of glomerulus. Again, so it could be, again, deposition of immune complexes or the reaction of antibodies mismo against glomerular antigens or other antigens such as bacteria or mga drugs na antigens that were found or that are found inside the glomerulus. So that's the main pathogenesis, or mo na siya yung main na most common na cause of glomerular disorder. Aside from that, of course, there could be metabolic disorders such as katong mga overflow amino aciduria, all right? Metabolic such as diabetes, Japan, diabetes mellitus, of course, diba? Increased glucose, and that glucose can elicit changes in mohang glomerulus, yes, increased glucose, diba? And of course, hereditary disorders. There could be damage already sa glomerulus, na genetic changes, all right, because of hereditary diseases, okay? All right. And again, as I mentioned, the most common din na cause are immune-mediated, all right? Now, your glomerular disorders can be divided into two pagyud na categories. You have the primary glomerular disorders, which is also known as your glomerulonephritis, ayan, glomerulonephritis, and you have the secondary glomerular disorders. So nasa pangalan pa lang, glomerular disorder, of course, glomerular disorder, or primary rather, glomerular disorder, of course, sa kidney jud mismo ang problema, no? Or there is a problem or there is a defect in the glomerulus agad-agad, all right? So it specifically affects the kidney and usa ra ka organ gyud siya ra ang na-affected. Whereas for the secondary glomerular disorders, these are usually mga systemic disorders na possible na nag-start sa ubang organs and then nadamay na lang ang kidneys, okay? So that's secondary, okay? So secondary na lang sila sa initial disease, no? So nadamay ang glomerulus, no? The glomeruli became involved, all right, in the disease process that initially started from another area in the body. So this usually indicates mga systemic disorders such as SLE, no? Systemic lupus erythematosus, mga diabetes mellitus, ganun. All right? Okay. Now, non-immunologic causes, of course, can also damage your glomerulus, such as mga harmful chemicals and toxins that can affect your glomerulus and also tubules, especially the tubules. Disruption of the electrical membrane changes, of course, which is seen in nephrotic syndrome. Deposition of amyloid material from systemic disorders, and that may lead to inflammation. And of course, the thickening of the basement membrane because of diabetic nephropathy, which is due to increased glucose concentration. All right, so those are the different causes of your glomerular disorders. But again, the main cause, or the most common is your immune-mediated. All right, and this is from Renzel Deers, the table. What are the different glomerular disorders? Again, primary, as you can see, it's all affecting the kidneys lang, no? Kidneys ra gyud, usa ra ka organ. All right. For secondary, as you can see, it's all systemic or pwedeng hereditary. So it did not start from the kidneys, no? The disease started from another area in the body, and it only involved, na-appeal na lang, na-alahig, ayan, na-appeal, or it involved na the glomerulus secondarily, no? So complication na lang siya sa initial disease, all right? Okay, that's for the different classifications of your glomerular disorders. Now, generally, dears, sa tanang kidney diseases, all right, one of the main hallmarks, ayan, one of the main definitive talaga na parang marker sa imuhang urine that could indicate a kidney disease, bahala glomerulus, tubular ba na siya, or whatever in origin, is of course the presence of unsa man na chemical sa imong urine, protein, di ba? We have already established that sa chemical example lang, that the presence of protein is highly indicative talaga of renal disease. Why? Because again, protein is reabsorbed, okay, by the body, all right? So the presence of or because of normal functioning of the kidneys, of course, especially sa glomerulus, protein, especially albumin, cannot pass through the glomerulus because of the different charges, shield of negativity. So the presence of this protein, okay, in large amounts in your urine could indicate, again, there's a possible disruption, no, in your glomerulus and in the tubules foot, which could indicate a possible kidney disease. All right. So, kung question kay hallmark, ayan, hallmark for kidney disease, of course, atong answer is proteinuria. All right, protein. Okay, that's one of the early signs. Okay, and hallmark yun for a kidney disease is your proteinuria. All right, so that's generalized. No, bahala kung sa na kidney disease, mapaglomerular, tubular, or whatever. Okay, all right, sige. So now start with the different morphological changes. Let's say may tabo sa glomerulus. So for the glomerulus, of course, morphological changes, there can be 4 distinct morphological changes. Number 1, there could be cellular proliferation. So pwede siyang daghan ihang cells sa endothelium of the glomerulus in response, no, to the deposition of immune complexes ba, or in response to different metabolic disorders, or in response to mga toxic substances. Number 2, you have leukocytic infiltration in cases of inflammation. No? So it will attract WBCs there and cause inflammation. Glomerular basement membrane thickening. It also happens if kanang mag-deposit. There's deposition, again, of mga immune complexes, no? Circulating immune complexes, mga proteins, no? If daghan kayo lang concentration, which can lead, again, to inflammation pa rin. And lastly, hyalinization with sclerosis. So what happens is, pag-deposit, example sa amyloid, ayan, iyang i-deposit sa glomerulus, if dagan sila, ma-deposit dito, and in the long run, mamatay, no? Or sclerotic, ayan, mas-sclerotic imong glomerulus. Kaya naman siya ay deposited na material, alright? So, that's the different morphological changes sa imong glomerulus, alright? And one or more of these changes may accompany each type of glomerulonephritis, and which forms the basis for characterizing the diseases. Okay? And for the pathogenesis, again, as mentioned, majority talaga is immune mediated. All right? So the first mechanism is, again, the deposition of circulating immune complexes, meaning nanay mga immune complexes, antibody antigen na forms in imong body, and then of course, ma-filter sila sa kidneys, it will get deposited sa imuhang glomerulus. And immune complexes, remember, it can activate the complement system. Okay? So therefore, mag-complement system, activate the complement system dito sa glomerulus, alright? And of course, the byproducts or the effects of the complement system will be experienced by the glomerulus. That's why it causes inflammation or damage. Okay? Another mechanism is the actual guild interaction of an antibody, mga antibodies against the glomerulus mismo, alright? Antibodies against the glomerular antigens, mga autoimmune diseases, or again, antibodies against other antigens such as bacteria, mga drugs na naa sa glomerulus or na na-filter sa glomerulus at that time. Okay, so they will react, okay, form immune complexes, activate the complement, and of course, again, the byproducts which are toxic, no, and cell lysis, of course, for complement, it can affect or it can be experienced by the glomerulus. Hence, that's why pwedeng mo damage ang glomerulus. So as you can see, as mentioned, glomerular injury does not occur, or it's not because of the deposition yun mismo, all right? But rather, it's the effect, ayan, the chemical mediators and toxic substances that are produced after activating the complement, all right? After the inflammation brought about by the immune system, such as the production of neutrophils, the different WBCs, all right? And mga byproducts nila after, no, digesting and after eliminating those immune complexes. So, if dili yun ang immune complexes per se ang nakadamage sa imong glomerulus, it's not the deposition, but rather, it's the effect, no? It's the reaction of the immune system against these immune complexes that damages, no, your glomerulus, no? So, activation of the complement system, byproducts of the neutrophils, WBCs, after eliminating these immune complexes, all right? Which damages the glomerulus, all right? So, that's for the pathogenesis of your glomerular disorders. Okay, so we'll now start with the different types, no? Different types of your different types of glomerular disorders. All right. So again, dears, medyo summarize lang ni siya ha. So dili siya in-depth yun na we'll talk about the pathophysio talaga, na intense yun, mga ginagmay lang. All right. You'll have this more when you go to medicine, but for our purposes lang as medtechs, of course, because we cannot diagnose diseases, we just know kung sa mga possible results. Okay, so ato ang purpose is kung sa makitaan sa urinalysis, okay, and in a way, a short description of what the disease is about, of course, and other significant tests can be performed. All right, so number one is, of course, your acute post-streptococcal glomerulonephritis. And I'm sure you're all familiar na sa bacte, gas na. Streptococcus pyogenes, especially when there is pharyngitis, no, throat infection, or skin infection. One of the important sequelae or complications is, of course, AGN, acute glomerulonephritis or acute post-streptococcal glomerulonephritis. All right, and this is also known as your Bright's disease. Nako, sana na-remember pa. Okay, so Bright's disease. So what happens is, of course, circulating immune complexes, no, antibodies of your body reacting with the streptococcal antigens, they form immune complexes. And these immune complexes will be deposited sa imong glomerulus. And these immune complexes, of course, katong na mention, it will trigger the immune system, of course, and lead no, to the damage of the glomerulus. So muna siya pathophysio, all right, or the cause, no, etiology of the disease. So immune complexes of the streptococcus pyogenes na antigens with your antibodies. All right. So for clinical course, of course, it's rapid onset of hematuria and edema. So there could be bleeding because again, there's damage of glomerulus, and because there's damage of glomerulus, there could be proteinuria. So therefore, edema. But thankfully, kanisha, it rarely progresses to chronic glomerulonephritis, rarely lang, and permanent renal damage seldom occurs. So dili kayo siya na maagapan lang siya. Okay, prognosis is also good lang for patients. All right. Now, what are the expected results for UA? Of course, there's hematuria, ayan, macroscopic. Proteinuria, of course, there's dysmorphic RBCs, RBC casts, and of course, granular casts because it involves the glomerulus. Okay, all right. Now, other significant tests, of course, positive for ASO titer. Of course, very ano na, no? Press the buzzer now. Of course, there was an initial infection with Streptococcus pyogenes. Okay, so therefore, taas na yung ASO. So, ano na ASO? Anti-streptolysin O na antibody. Okay nga no? Okay, ito, ako na lang na siyang i-ask sa live session natin. Okay po. Alright, okay. And aside from ASO, of course, you have the other anti-streptococcal A enzymes, such as your anti-DNase B. Alright, ang mga streptozyme testing. So, I hope na remember pa ni siya, no? Sa IS and even sa back test. So, those are the possible significant tests. So, for case studies, no? Naagi na siya, press the buzzer good kaayo, no? So, for urinalysis, result na daw nakitang RBC casts, na hematuria, na proteinuria. Additional pag yun na ibutang is positive siya sa ASO titer. So, my God. Very, very, press the buzzer na yun. So, ang answer na to is, of course, APGN, acute post-streptococcal glomerulonephritis. Basta ka na ang mga results, okay? So, very specific mga case studies na to. Alright? Next, you have your rapidly progressive glomerulonephritis or also known as Chrysanthes. So still, ang iyang etiology is still the deposition of immune complexes, usually from a systemic disorder such as SLE. And what happens is these will elicit or induce cellular proliferation, all right? And the Bowman's capsule will form crescents. Iyang shape of cells na ni proliferate kay murag crescent in appearance. So later na i-picture, all right? So muna siya, crescentic. That's why it's called crescentic. So for clinical course, rapid onset, damage sa glomerulus, and possible progression to end-stage renal failure. True enough, there's condition of disease, 90% yun, mo progress siya to end-stage, no, or renal failure, 90% yun. Medyo taas yung chance na mo proceed siya to chronic glomerulonephritis, okay? And of course, eventually renal failure, right? So taas ang chance niya, okay? Because again, this is due to sorry. This is due to, again, the deposition of immune complexes, again, from usually systemic immune disorders, such as your SLE. So, pwedeng daghan kay immune complexes na ma-produce or ma-deposit, okay? So, very intense ang complement activation, okay? Kay daghan mga immune complexes, so ma-deplete imuhang complement levels, okay? So, therefore, possible po na intense ang pathology na mahitabo sa glomerulus, okay? And again, often progresses, good siya, mo-progress siya to chronic glomerulonephritis and eventually, pwedeng renal failure, alright? For UA results, of course, primary pa lang. So you have macroscopic hematuria, proteinuria, and still RBC casts. And other significant tests, you have BUN, creatinine, and of course, creatinine clearance, because we mentioned that it can lead to possible renal failure. So we have to monitor the ability of the kidneys to filter, no? And a kidney function test. So of course, we measure BUN, CREA, and creatinine clearance. Okay? So, basta there's inyo hang ma-notice, basta for glomerular disorders yun, the most common, no? Pinaka-common yun na ito makita sa atong urinalysis results are number 1, proteinuria, naging proteinuria, because again, that is indicative that there's damage sa glomerulus. Number 2, the presence of casts, okay? Especially if may bleeding. So, kung glomerular disorders, usually mga RBCs, no? RBC casts, okay? And if mo progress na ang disease to chronic, basta na gani chronicity or dugay na gani, ang casts na ma-form kato ng mga chronic or pangdugay, which are your broad, mga waxy casts. So, muna siya ito makita. So, that could aid us in the identification of the disease, especially in case studies. So, kung na kayo mga case studies na gibutan itong result, kaya yung mga waxy cast, na yung mga broad cast, na press the buzzer, alam nyo na yung answer. Dapat imong latawon sa choices na ay chronic. Okay? Mo-choose kag mga chronic na diseases dito. Pero kung ang given na sa urinalysis kay mga RBC casts, no? Hematuria, mga inana, RBCs, makitaan, inana. So it could indicate acute pa lang. Alright? Basta wala pa yung mga waxy casts or mga broadcasts. Basta kanina na present sa waxy cast or broadcasts, it indicates chronicity. Chronic na yun ang infection or disease. Okay? So it can really help us sa case studies. Okay? Alright, ayan. Sige. So here's an example of your crescentic. As you can see, ayan. I-trace na nila. Ayan, crescent. So this is the normal, this is the capillary loops and the Bowman capsule. As you can see, ni proliferate ang cell and deform siya o crescent. Ayan, that's why it's called crescentic. As you can see, ang normal tubule in ani, medyo clear lang. Pero as you can see, kanin sa tunga na ay progressive crescentic na formation, medyo ni-compul siya and nibaga ang cells sa kilid. Alright? And it formed a crescent. That's why it's called Chrysanthes glomerulonephritis. Again, there's a very basic lang ni siya kung ma-offer ninyo because dili ko pathologist. But in the future, if mag-pathologist mo, yes. So, muna inyong mga forte, okay? Kanang paglantaw sa mga tissues. That's my weakness yun, so my goodness. Alright? Okay, sige. Alright. Next, we go now to mga autoimmune diseases actually. Number one, you have the good pasture syndrome. For good pasture syndrome, it's the reaction of an antibody against the glomerular membrane. No? So it's an anti-glomerular basement membrane antibody. But aside from that, it can affect also the lungs. All right, not only the glomerulus but also the lungs, because the lungs have a basement membrane, and the antibody produced can react also with the basement membrane of the alveoli. All right, so therefore, your clinical course, aside from having kidney disorders, there could also be respiratory conditions or symptoms such as hemoptysis. All right, so bleeding, anay blood sa cough, dyspnea or difficulty in breathing, and of course, there could be hematuria, so involvement sa kidneys. And this could progress again, Japon, to end stage renal disorder or renal disease. Okay? So for urinalysis results, the same Japon, RBC cast, hematuria, proteinuria. And for other significant tests, the measurement or the detection of the autoantibody, anti-glomerular basement membrane antibody. Okay? So again, what you have to take note here is, again, it can affect your both the kidneys and the lungs. Okay? All right. Okay. So it involves rapidly progressive, no, paspas iyahang onset. It could lead to kidney failure and develops in days to weeks, along with lung disease. All right, but some diseases pwede lang mo involve either of the two. All right, or pwedeng both. So depende sa disease, pwedeng lungs ra or kidneys ra alone ang affected, or pwedeng duhag yun. All right, and this disease resembles katong rapidly progressive glomerulonephritis. So it may resemble that. Okay, but again, the main goal lang here, or the main characteristic, take note, there is an autoantibody involved. And unsa siya autoantibody? Anti-glomerular basement membrane. Okay, all right. So that's for good pasture syndrome. Next, you have Wegener's granulomatosis, or also known as your granulomatosis with polyangiitis. So this is still an autoimmune disorder, and ang iyahang antibody produced is your anti-neutrophilic cytoplasmic autoantibody, your ANCA, ANCAs, all right, which binds to neutrophils in the vascular walls, producing damage to small vessels yapon sa lungs and glomerulus. So medyo same siya presentation, or same siya mga organs involved sa imong good pasture. It also involves both the kidneys and the lungs, because again, antibodies to neutrophils, and again, neutrophils could be present in your lungs and kidneys normally, so therefore possible na mo react sila, okay, and elicit complement and all that, which damages the vessels sa imuhang lungs and sa imuhang kidney. So for clinical course, do the same, pulmonary symptoms following, including hemoptysis, and then followed by renal involvement. And again, same with good pasture, it can progress to ESRD, or end-stage renal disease. So for UA results, same ragyapon, and for other significant tests, the detection of the autoantibody. All right, so how do we remember? Muna kong ano dear, how do you remember, especially sa IS, okay, kani mga autoimmunity, you have to remember the autoantibodies involved, di ba? So for good pasture, di ba? Good pasture, letter G. So therefore, iyahang autoantibody is letter G po, glomerular. Ayan. Anti-glomerular basement membrane. But for Wegener's, ayan, iyaha kay ANCA, anti-neutrophilic cytoplasmic antibody. So how do I remember WC na lang? Medyo weak ako ang mnemonics for this. Maglibog pa po nila ako sa highlight. Pwede ako sila mag-interchange. But always remember lang na GG, good game. Good pasture, anti-G, glomerular basement membrane. Okay? So good pasture, anti-G, anti-glomerular basement membrane. And Wegener's WC, ANCA, anti-neutrophilic cytoplasmic antibody. Okay, alright. Alright, next you have your Henoch Showin, Henoch Showin purpura. Ayan. So it usually occurs in children following viral respiratory infections. There is a decrease in your platelets, all right, which okay, all right, so noted, which again disrupts vascular integrity. So therefore, because your platelets, diba, could maintain your vascular integrity. So therefore, there is a disruption in the platelets and can lead to the disruption of vascular integrity. So of course, pwede ma-involve ang glomerulus. Okay? Alright, so its initial appearance of purpura. Of course, diba, purpura is mga dagko na petechi, di ba? Ayan. Followed by blood in sputum and stools and eventual renal involvement. Complete recovery is common, pero it can progress down to renal failure. Alright? So for UA result, ayan, there could be macroscopic hematuria pa rin, proteinuria, and RBC casts. As you can see, positive po siya, or you can test also for stool occult blood. Alright? Because again, it's involving the vascular integrity. So possible ma-involve ang mga blood vessels sa intestines. Okay? So therefore, there could be bleeding there. Alright? So that's why you can test for stool occult blood. Okay? Alright. So here is an example. Ayan. For classic tetrad, abdominal pain. Ayan. You have purpura, your hematuria, and also arthritis. So again, it can possibly affect a lot of blood vessels. All right. And again, it can involve, it's usually common sa mga children. All right. Okay. So there could be also deposition of IgA in the different skin, mucous membranes, kidney, and of course, abdominal vessels. And again, it typically is preceded, meaning nauna na upper respiratory infection, which is usually viral in origin. Okay? All right. So that's for your Henoch Showin purpura. Okay. All right. I'm sure na-discuss ni sa HEMA po, ang Henoch Showin. I remember that. Okay. Next, we go now to your membranous glomerulonephritis, which is the most common cause of nephrotic syndrome in adults. All right. So what happens in membranous glomerulonephritis? Thickening, no, mubaga ang glomerular membrane because of the deposition of IgG. Ayan. Immune complexes associated with, again, systemic disorders. So again, such as SLE, okay, or other systemic disorders. So there's the position of IgG. Okay. All right. Okay. Ayan. This is again partly due again to complement activation yapon. So activate ang complement, so therefore it damages na po the kidneys, okay, and the glomerulus. All right. Okay. Now, 85% of the patients with membranous GN or glomerulonephritis is idiopathic, meaning wala kabalo kung asa gikan ang disease. All right. But the other percentage, ayan, it may be associated again with immune-mediated disease. All right. It could be exogenous ang antigen, such as gikan siya sa syphilis, ayan, treponema, or pwede siyang endogenous, mga thyroglobulins or DNA, and many antigens remain unknown. All right. Remember, this glomerulonephritis can occur also secondary to other conditions, such as, again, mga systemic disorders such as SLE, DM, thyroiditis, and even exposure to metals such as gold or mercury, and mga drugs such as penicillamine. Okay, so muna siya mga possible causes ng membranous glomerulonephritis. But again, the main pathology there's deposition of IgG. And again, this can elicit complement activation, therefore damaging the glomerulus. All right. Now, take note there's that membranous glomerulonephritis can progress to nephrotic syndrome. So therefore, yung primary UA result, again, same gapon, hematuria or proteinuria, but in the long run, later run, pwede na siyang same of results sa imuhang nephrotic syndrome. Okay? All right. Now, other significant tests, of course, you have ANA, di ba, for SLE, anti-nuclear antibody. You have HBsAg, possible siya na secondary to hepatitis B infection, and you have fluorescent troponemal antibody absorption test, okay, FTA, ABS, for, again, cases of syphilis. Okay, because we mentioned na possible po siya secondary sa treponema antigens or cross-reaction or reaction of the treponemal antigens with the antibody, IgG, and of course, deposition na sa glomerulus. All right, that's membranous glomerulonephritis. Again, the most common cause of nephrotic syndrome, again, in adults. So it starts first as membranous and then becomes nephrotic syndrome in the long run. Okay. Now, for membranoproliferative, or also known as mesangiocapillary glomerulonephritis, as you can see, cellular proliferation of the capillary walls or the glomerular basement membrane, again, still the same, immune mediated. All right. So again, it can progress to chronic glomerulonephritis and nephrotic syndrome. So as a result is still the same, hematuria, proteinuria, and for other significant tests, you may measure again serum complement levels, because again, it could be depleted because again, there's immune complex deposition sa glomerulus, which can activate the complement. Okay, so that's for your membranous or membranoproliferative. Okay, so so membranoproliferative, no? So murag ni-proliferate ang cells, nasa pangalan na. I-change ang membranous structure, microscopic structure of the kidney cells and the peripheral capillaries. All right. Okay. So there could be deposits in the glomerular basement membrane. And again, it can lead to symptoms such as edema, hypertension, hematuria, and of course, proteinuria. This for membranoproliferative glomerulonephritis. Again, for membranous and membranoproliferative, it can lead to nephrotic syndrome and even chronic glomerulonephritis. Okay, all right. Okay, next, of course, is your chronic glomerulonephritis. So, nasa pangalan natin. So, this is a glomerulonephritis that persists for a long time. Okay, so chronicity, long term. Ayan, sana all nagdugay, charot. Okay, ayan. So, okay. Okay, all right, sige, tama. Ayan. So again, chronic GN. So it's prolonged na yun. So dugay na siya nahitabo. So therefore, there is already marked decrease in the renal function. All right, kay dugay na yun siya. And it may have arise, nagsugod siya from an initial other kidney disorder such as membranous ba siya, na GN, membranoproliferative, katong rapid progressive ba, or whatever. So it started from there and then ni long term siya or nagpadayo na mo siyang chronic GN. Okay, so again, since chronic naman, nagdugay na, so of course, kidneys will now become more damaged. So therefore, there's marked na good in renal, marked decrease in renal function, and it can progress na to renal failure. Yes, because chronic GNs, of course, medyo na-adjay daghang damage na sa glomerulus, sa kidneys mismo, so there's marked decrease in your renal function. All right. For clinical course, of course, noticeable decrease na renal function, progressing to renal failure. So, ang kidney function test nimo medyo elevated na. Imong creatinine clearance is decreased. Okay. So, therefore, your kidneys is starting to fail na. Dili na niya kaya mo filter, mo accumulate ng mga toxic substances. Of course, azotemia and uremia, di ba? BUN, creatinine taas na kaayo. All right. And for UA results, of course, as I've mentioned, basta gani chronicity, ang atong latawon kay mga casts na pwedeng ma-form. And again, ang ma-form na ng mga casts are the casts that are usually signifying prolonged urine stasis or prolonged course of infection or disease, which are again your waxy and mga broad casts. Okay, basta gani dear, as I've mentioned, sa case studies na yung mga inana gani, nakitaan daw sa microscopic na yung waxy na yung broadcast. Nako, press the buzzer, look at the choices, find a disease na chronic, no? If na chronic GN dito, very good mo na siya answer, okay? All right. Basta ganyan yung mga waxy broadcasts, okay? Because again, these casts indicate prolonged urine stasis, dugay na gid kaayo nagpundo ang ihi because again, medyo dugay na po ng disease. All right? Okay, so that's for chronic GN. But again, it can come from initial, mga starting na other kidney diseases or glomerulonephritis, and then wala na agapan, wala na tambalan, so of course, ni progress siya to a much more severe form, which is now the chronic GN. Okay? All right. Now, here is an example of your Membranos Glomerulopathy. As you can see, ayan, this is the normal capillary. As you can see, medyo thin lang, or as you can see, ni baga siya. So, membrane or medyo ni baga siya, yes. So, na deposition that happened, all right? So, membranous. And for membranoproliferative, as you can see, iyahang capillary wall, thin lang, ayan, as you can see. But as you can see, there's an increase in the number of cells. All right, so membranoproliferative, nasa pangalan na, proliferate, no? Didaghan ang cells. All right, excuse me. Okay, all right, so that's for the different glomerulonephritis. Okay, all right. Now, another is, of course, your IgA nephropathy, which is considered to be the most common cause, ayan, of your chronic GN. Okay, so IgA nephropathy, also known as the Berger's disease. So there's deposition of IgA on the glomerular membrane because of increased levels of IgA. All right. For clinical course, hematuria following exercise. All right. And slow progression to CGN or chronic glomerulonephritis. Again, this is considered to be the most common cause of your chronic GN or chronic glomerulonephritis. Okay. All right. Okay. Okay. All right. So these IgA complexes or aggregates, okay, circulating in the body, they may be engulfed or trapped in the glomerulus. All right. And this aggregated IgA, again, remember, it can activate the complement, your alternative pathway. So therefore, again, causes damage to your glomerulus. Okay. All right. Now for the expected UA results, again, for early stages, again, hematuria muna. All right. And for late stages, it resembles na chronic GM. So na mga waxy casts, no, fatty casts. Ayan. And for other significant tests, of course, you measure IgA. Okay? All right. Ayan. Now, of course, next is nephrotic syndrome. Very, very popular talaga mga press the buzzer na disease. Okay? And very distinct. For nephrotic syndrome, the etiology is, again, it's actually a group of syndromes, no? Or a group of symptoms brought about by, again, a disruption in the electrical charges of your podocytes, all right? And because of that, natangtang ang shield negativity, all right? Naguba, all right? And because of that, there is massive loss, kanadyo na term here, ha? Massive loss of proteins and lipids, which are, again, supposedly dili ma-filter out. Because, again, these substances could be large, and aside from that, ilahang charges, mo-repel unta siya sa shield negativity. But because the electrical charges, the podocytes in your glomerulus have been damaged, okay, then of course, the appearance of these substances will be found or will happen in your urine, okay? So for clinical course, again, there's acute onset following systemic shock, gradual progression gyapon from other glomerular disorders, and then to renal failure. As mentioned, di ba, other katatong na mentioned kanina, like there's atong membrano proliferative, membranos, no? Focal segmental later, kung ato i-mention, they can progress to nephrotic syndrome. Okay? So again, when you say nephrotic syndrome, again, there's a damage na to the charges, okay? Especially the shield of negativity, again, that prevents unta. That prevents unta the filtration or the appearance of these proteins and lipids sa imuhang ihi. All right? Membranos Glomerulonephritis, as we've mentioned, is the most common cause in your in adults. And another name for nephrotic syndrome is nephrosis. All right? So nandiyo problema na, no? Naguba na gud ang glomerulus in terms of the charges. All right? Now, treatment may be required for life for adults with this condition. All right? So again, other diseases, initial diseases sa kidney such as minimal change disease, membranous glomerulonephritis, focal segmental, membranoproliferative, again, these can progress to nephrotic syndrome. Okay? Systemic diseases also can present with nephrotic syndrome such as your DM, SLE, amyloidosis, malignant neoplasms, and infection. And as well as mga different nephrotoxic agents such as your drugs and mga poisons. All right? So there could be a lot of reasons here, no, as to why the patient may have nephrotic syndrome. All right. Now, very important here, atong i-mention good ang mga findings, ayan, both in serum and urine. Now, again, take note, remember that the glomerulus has a shield of negativity, all right? So, point ka ng shield of negativity is, again, to prevent mga small molecules such as your albumin, protein talaga, na mo-appear sa urine. Because, again, albumin is negatively charged, okay? And the shield of negativity is, of course, negatively charged po. So, like charges repel. Because in terms of size, ni albumin, it's 69,000 Dalton. So, therefore, pwede na siya ma-filter. Because, again, remember that selective filtration sa glomerulus happens kung greater than 70,000 imuhang weight na Daltons, di ba? But for albumin, since 69,000 man iyahang weight, pwede na siya makalapos sa glomerulus if not for the shield of negativity. Okay, but in nephrotic syndrome, because of the damage to these electrical charges, makalusot ra gyud, no, imuhang albumin. That is why there is massive proteinuria. Take note of that, no? Massive proteinuria. So, magsige kang paggawas of proteins. Not only even albumin, majority is albumin. Pero of course, the low molecular weight na mga proteins which are negatively charged, such as your mga gamma globulins, alright? Imuhang mga anticoagulant factors, ayan, pwede silang ma-produce sa imuhang or mo-appear sa ihi. Pwede silang mugawas, alright, sa imuhang ihi. So therefore, patients also that have nephrotic syndrome are prone to thrombotic, ayan, mga thrombotic complications. Kaya wala sila anticoagulant factors na sa lahang blood. And aside from that, they can be also prone to infections because again, mga gamma globulins, mga acute phase reactants, they can also appear in your urine because again, massive proteinuria. Wala na control, no, sa imuhang glomerulus, alright? Because wala na siya shield negativity. So therefore, kung daghan man kayong protein sa imuhang ihi, sa serum therefore, kung sa expected, low levels. Low levels of albumin, the alpha-1 globulins, and of course, the gamma globulins. Because again, these are usually the low molecular weight ng mga proteins which can easily pass through the glomerulus. Alright? So, hypoalbuminemia. Gamay na lang imuhang levels of albumin sa blood because again, majority are excreted sa ihi. In comparison, unsa increased alpha-2 macroglobulin. So nasa pangalan na, ano man siyang increase? Because dako siya, macro, no? It cannot pass through the glomerulus. Although naguba ang glomerulus, pero ang charges naman ang problema. In terms of the size, dako ra gyud siya ang alpha-2 macroglobulin, so dili siya kagawas sa imuhang glomerulus. All right? And of course, increase po ng beta globulins, especially the beta lipoprotein, which is, ang sabi ng beta lipoprotein, your LDL, di ba? And because of your LDL, there is increase in lipids, okay? So there is increase in lipid production. So the reason is wala pa jud na understand, pero it's partly because there's a decrease in albumin, okay? So the liver compensates by producing more lipids, okay? So that's why there's hyperlipidemia. So daghan ting lipids sa imuhang blood, so therefore daghan pong lipids na ma-produce sa ihi. Because again, the lipids can also pass through sa glomerulus. So therefore sa imuhang serum, there's an increase in the beta globulins because of the beta lipoprotein, which is lipid na taas. Okay? Taas in concentration. Again, so for serum, unsay levels natong makitaan, there is hypoproteinemia or hypoalbuminemia, and there is hyperlipidemia. So gamay ang protein sa imuhang blood, pero daghang lipid sa blood. In contrast sa urine, of course, daghang proteins na dito. So there is proteinuria, okay? Massive proteinuria in your urine, and of course, there's also massive lipiduria, okay? Because again, daghan mang lipids na produce ang liver to compensate again the decrease in albumin sa imuhang lawas. So produce siya og lipids, okay? So daghan man siya na produce na lipids, of course, daghan pong lipids na ma-produce sa ihi because the lipids can also pass through sa glomerulus. So therefore, there is massive proteinuria and massive lipiduria. All right? So that's the expected results in imuhang urine. All right? But take note, negative siya for alpha-2 macroglobulin. Ano ganito? Because again, of its large size, dili siya ka-pass through sa imuhang glomerulus. Okay? That's why dili siya makitaan sa imuhang ihi. So take note of that ha. In nephrotic syndrome, kung say wala sa ihi, alpha-2 macroglobulin. All right? And of course, for the microscopic, as I mentioned, ito ng mga daghang fats. Oval fat bodies, fatty casts, fat globules, mga fat droplets, waxy casts, and also cholesterol crystals. Because again, these are all lipids. And as mentioned, again, there's mga case studies, mentioned gani, massive proteinuria, massive lipiduria, the appearance of the oval fat bodies, fatty casts, waxy casts, fat droplets, cholesterol crystals. Nako, press the buzzer. Huwag na mag-isip. Okay? Pangitaan na dayon ang choice na nephrotic syndrome. Okay? Please, dear, take note of that. Okay? Ako nag-emphasize. Alright? So I hope na-get lang to siya. So in a nutshell, ang problema are the charges sa imuhang glomerulus. So what happens is, imuhang permeability sa glomerulus na alter. Okay? Instead na dili siya ma-filter, your proteins and lipids, mo-appear na noon siya sa ihi because na-disrupt ang podocytes, no? Ang charges niya. Alright? So therefore, mugamay ang protein sa imuhang blood. So there's hypoalbuminemia and also the low molecular weight proteins such as alpha-1 globulins and mga gamma globulins, all right? So therefore, the patient may be prone to infections and also mga thrombotic complications because nawala po ng mga anticoagulant factors, no? Pwede siyang maihi po, anapil siya sa ihi, all right? And there is an increase in alpha-2 macroglobulin because of its large size, dili siya ma-filter, all right? And there is an increase also in beta globulins because the liver compensates for the decrease in your protein by producing more lipids. Okay, so therefore there's hyperlipidemia, hypoproteinemia. All right. For urine, of course, dito ang daghang protein. That's why there's massive proteinuria. Pero you cannot see alpha-2 macroglobulin sa ihi because again, ngano to, wala siya na filter kay dako iyahang size. Okay, all right. And of course, there's also lipiduria in your patients with nephrotic syndrome. Why? Because again of increased production of lipids by the liver. And your lipids can also pass through sa glomerulus, kaya wala na itong shield of negativity. So therefore, lipids will appear in your urine. And these lipids can be incorporated into different cells and mga casts. Therefore, makakita oval fat bodies, waxy casts, fatty casts, cholesterol crystals. Alright, so take note of that. Alright, basta ganyan yung mga fat. Alright. Now take note also, dears, because there is protein loss. So the patient also, of course, exhibits edema, all right? Edema, okay? But the main cause of the edema, dears, is the decreased excretion of sodium. Ayan, so there's sodium retention in nephrotic syndrome. So the mechanism is still not known, all right? But that's the main reason why there is edema. Secondary na lang ang protein loss. Because again, di ba, albumin maintains the oncotic pressure, osmotic pressure, all right? And without the protein na mo-hold sa fluid inside the blood vessels, okay, wala na may protein na mo-hold, so tanang fluid mugawas na sa blood vessels or sa mga interstitial spaces. That's why manghupong ka, no, manghubag, no, edema. Because again, wala na yung protein na mo-hold sa fluid within the blood vessels. Because again, it maintains osmotic pressure. All right? Okay, that's for nephrotic syndrome. I hope na-gets lang to siya, dears, ha? Basta ganyan itong mga keywords, massive proteinuria, massive lipiduria, basta ka na ng mga terms na compress the buzzer, that is nephrotic syndrome. Huwag na mag-isip. Okay? Alright, ayan, sige. That's for nephrotic syndrome. So here again is an example, no? Nephrotic syndrome, again, hypercoagulable state. So possible siya mo-produce mga thrombosis, no? Mga clots, hypercoagulable. Ayan. Because again, nawala iya mga natural anticoagulant factors such as antithrombin 3, alright? Because again, nakagawa siya sa glomerulus. There's hypoalbuminemia, usually sa peripheral, edema, and periorbital, sa mata, alright? And massive proteinuria, pila ka grams, about greater than 3.5 grams of protein per day. Imagine na, again, kaayog yun, alright? Okay, so that's for nephrotic syndrome, okay? So again, these are the main causes possible, mga minimal change disease, focal segmental, membranoproliferative, sila ang possible na mag-progress to nephrotic syndrome. Secondary, DM, diabetes, no? And also SLE, systemic lupus erythematosus and amyloidosis. All right? Okay. So that's for your nephrotic syndrome. Okay. Now we go na to your minimal change disease, also known as lipoid nephrosis or NIL disease, no? So by the name itself, minimal, no? There are little cellular changes to the glomerulus, all right? And the podocytes are also disrupted and usually seen in children following allergic reactions or even immunizations. All right, so that's a pangalan na minimal. All right, okay, so gagmay pa lang, no? It has a much more favorable prognosis than the Membranos Glomerulonephritis. All right, okay. Clinical differentiation, dears, MCD or minimal change disease can respond to corticosteroid therapy, whereas your Membranos Glomerulonephritis, dili siya mo respond to corticosteroid therapy. So that's why mas medyo poor ang prognosis sa membranous. No? But for minimal change disease, which is common in children, pwede na siyang medyo good yung prognosis. Okay? There could be a lot of reasons as to why there could be minimal change disease. Again, possible immunizations or other infections. But also if the patient or the child has an HLA. Ayan. Kung sa mga HLA, human leukocyte antigen, diba? We mentioned na kanang mga HLA, diba? Sa ito ang MHC or major histocompatibility complex. So mga kinsa na HLA for minimal change disease, HLA B12. Alright? So HLA B12, nasa MHC class 2 ni siya. HLA B12, alright? Ayan. So if ang patient contains this antigen or this human leukocyte antigen, then mas prone siya to develop minimal change disease. Again, unsa na HLA? HLA B12. Again, unsa na disease iyang possible na ma-develop if naa siya ani na HLA, you have minimal change disease. All right, okay. Now, what are the expected results or urinalysis results? Again, as you can see, heavy proteinuria. There could be a transient hematuria and again, fat droplets. So it may resemble in a way ginagmay your nephrotic syndrome. Your nephrotic syndrome also may have also hematuria, no? Medyo pero ginagmay lang, all right? Because again, there's still damage sa glomerulus, okay? So it can also have hematuria. Pero again, as mentioned, basta nephrotic syndrome, atong mga press the buzzer na characteristics, massive proteinuria, massive lipiduria. Again, other significant tests, again, you have serum albumin, all right? Cholesterol, and also triglycerides, of course, because it can mimic or medyo same sila of presentations sa nephrotic syndrome. So as you can see, muna siyang normal na podocytes, di ba? Tight fitting, ayan. But as you can see, pag sa minimal change disease, medyo nawala, ayan. Nawala or diffuse ang mga podocytes, all right? Nawala ilahang tight fitting processes, all right? Okay, so that's for minimal change disease. All right, so minimal lang, minimal, nasa pangalan na, little cellular changes. All right. Next, you have focal segmental glomerulus sclerosis. All right. So it disrupts the podocytes. When you say focal, all right. Wait lang, let me check. Focal segmental, all right? When you say focal, it means that some of the glomeruli lang ang scarred, okay, or nagkaroon ng scarring, okay? For segmental, only part of each individual glomerulus. So again, as you can see, focal meaning kanira na part sa mga glomerulus ang na-damage, so focal. Segmental meaning sa sulod pag sa glomerulus na aray parts dito na affected. So focal meaning one dili jud tanan sa glomerulus as a whole ang na-affected, so only a part of the whole. And then sa sulod pagyod sa glomerulus, alright, small areas lang po or dili po tanang areas ang na affected. That's segmental. That's the point. So focal, again, only a part of the entire glomerulus. And for segmental, only parts lang within the glomerulus ang na-affected. Tama? Okay? Alright. Yeah. Only part of each individual glomerulus ang na-damage. Okay? Alright. So again, other areas remain normal. Pares ani. So kanira na area ang na-damage. So that's focal. Alright? And then sa sulod pag sa glomerulus, there is a cells niya, only a part ang na-damage. And the other side, of course, it's working properly. Okay, so that's the point. Focal segmental, no? Ayan. So it may resemble nephrotic syndrome or minimal change disease. So therefore, your UA results, of course, it starts with proteinuria and also hematuria. All right. For other significant tests, you may also perform drug of abuse na mga tests and also HIV tests. Okay, because again, it can cause or it can start from there. Okay. All right. So the cause is generally unknown, so it's still idiopathic. All right. Yeah, okay. So it also has little or no response to corticosteroid therapy. Okay, and again, FSGS can be sorry, can it can progress to nephrotic syndrome. Okay, all right. Okay, ayan. Okay. So immune deposits are also found in your FSGS. Okay, and it can be associated. It is seen in association with abuse of heroin and analgesics and also with AIDS. So possible siya na mga sequelae, no, from usage of drug of abuse such as heroin and analgesics and even pwede sa AIDS. All right, pero generally the cause of the disease is still unknown. All right, okay, ayan, that's for your focal segmental glomerulosclerosis. But again, ang point, pwede siyang mo-progress to nephrotic syndrome. All right, okay. So that's for your focal segmental glomerulosclerosis. Next, of course, your diabetic nephropathy or your Kimmel-Style Wilson disease. So again, it's the most common cause of end-stage renal disease. So it's a secondary disorder, glomerular disorder from diabetes. So what happens is, of course, the glucose, high concentration, it may be glycosylated with proteins, all right? And this will be deposited, no, on the glomerular basement membranes, which can lead to thickening of the glomerular basement membrane, all right? And can progress to chronic glomerulonephritis. All right. Primary UA results, very important, is of course, na-mention nato, microalbuminuria. Because again, positive result usually is an early indicator, no? Early indicator of kidney damage or diabetic nephropathy. And of course, other significant tests, you have blood glucose, okay? To monitor, no, and to note kung unsay ang plasma glucose, FBS concentration. Okay? All right. Next, of course, the last for the glomerular disorders, your Alport syndrome. So for Alport syndrome, usually there's a deficient, ayan, nasa picture, in the collagen 4. Okay? Non-functional collagen 4. What happens? It leads to the lamellated, so pwede magbuslot-buslot siya, and thinning, okay? Mugamay, munipis, muhang glomerular basement membrane. All right? So it also can progress to nephrotic syndrome and end-stage renal disease, pero medyo slow lang yung progression. So therefore, yung UA results similar to nephrotic syndrome. Possible na ay massive lipiduria, no, proteinuria gyapon, all right? And of course, other significant tests, genetic testing, because Alport syndrome is inherited, okay? It's rare in a way, and it's a genetic disorder, okay? All right, sige. So that's for the Alport syndrome. Whew. Okay, so as you can see, dears, as mentioned, a nephrotic syndrome is really a group, no, of disorders. It can arise from a lot, no, it can arise from a lot of diseases, all right, that started from other kidney diseases, okay, and then you progress to nephrotic syndrome, all right, okay. So again, for Alport syndrome, there is a defect in the collagen, no, collagen type 4 sa imuhang basement membrane, okay, all right. See, okay, I'm checking, all right. So that's for your glomerular disorders, okay, which are again including your Alport syndrome. That's the last, okay. All right, and of course here are the percentages that can progress, no, to glomerulonephritis. As you can see, ang RPGN, as we mentioned, 90% yun niya progress to chronic glomerulonephritis. So rapidly progressive, nasa pangalan siya, very progressive, no? So siya gyud ang mo progress to chronic glomerulonephritis. Followed by, of course, FSGS, focal segmental glomerulosclerosis. You have also Membranos Glomerulonephritis, MGN, and membranoproliferative, 50%. IgA Nephropathy, 30 to 50. And as you can see, post-streptococcal, medyo rare lang yun siya. No, it's not really common ang progressive chronic GN. So that's good. All right, so it has a good prognosis. All right, okay. Sige. Okay. All right. Okay. Okay. All right. Sige. So that's for for these percentages. Okay. So again, ang RPGN yun ang 90% ng progression to chronic glomerulonephritis. And of course, dears, we also have to differentiate the nephrotic from the nephritic. So na yung bang terms na mo mention na nephritic syndrome, nephrotic syndrome. So basically, ang nephritic syndrome, dears, kabante mo, it's really kato mga atong na-mention, glomerulonephritis, ang AGN, IgA nephropathy, no? Those na mga glomerulonephritis. So ang ilahag yun mismo, ilahang main definitive difference lang yun is hematuria, no? As you can see, nephritic, positive due to hematuria, and RBC casts. And as you can see po, proteinuria, common sa duha, pero ang massive proteinuria is found in nephrotic syndrome. So that's the difference. For nephrotic, it's really talking more about on the disruption of the charges, okay? But for nephritic, it's really sa cells yun mismo or sa glomerulus mismo na damage in terms of na-damage sa iyahang cellular endothelium that leads to bleeding, all right, hematuria, all right, and even proteinuria. So as you can see, di ba, ang nephritic syndrome, katulad itong na-mention kanina, IgA nephropathy, no, post-streptococcal glomerulonephritis, no, so katulad mga na-mention na unang glomerulonephritis. Pero for nephrotic syndrome, katuto siyang mga progress, no, from an initial disease, and usually ang problema kay sa charges, no, sa glomerulus. Okay, so that's the difference between nephrotic and nephritic. Okay, again, take note, proteinuria is massive and nephrotic. Okay, and for nephritic, massive ang hematuria or positive siya for hematuria. Okay, all right. But for nephrotic, medyo wala ang hematuria. Okay, all right. Sige, so that's for your glomerular disorders. No, so majority of the kidney diseases good kay usually glomerular disorders, and sila po ang mga most serious. Okay, all right. Sige. Now we go now to the next group, of course, the tubular disorders. So nasa pangalan na, tubular disorders, these are the disorders that affect the renal tubules, all right? So therefore, there could be a problem in the absorption, all right? The function of the tubules are disrupted as a result of actual damage because of mga toxic agents, all right, to the tubules, or there could be a metabolic or hereditary disorder that affects the intricate functions of your tubules, such as reabsorption, no? Or secretion mangani. Okay, so that's for the different diseases of your tubular disorders. Different tubular disorders. Okay, number one is of course acute tubular necrosis. All right, so nasa pangalan na, damage to your renal tubules caused by ischemia. So there is a there could be an obstruction dito, so nawala ang blood flow padulong sa tubules. All right, so na damage, or again exposure to toxic agents such as mga drugs, nephrotoxic drugs, or even mga poisons. All right. So it leads to again acute renal dysfunction that resolves or mawala after the removal of the impending agent or underlying agent, such as if di nakamutik sa drugs, okay, na nag-cause ato, pwede rang ma-normalize balik imong function, mawala tong poison or toxic agent, no, that is affecting the tubules, pwede rang ma-normalize balik. Okay? So of course, for UA results, we can see RTE cells and RTE cast because again, affected kay the tubules. Other significant tests, of course, hemoglobin, hematocrit, and the cardiac enzymes because again, there could be ischemia, no? So there could be an obstruction in the blood flow, possible sa heart ba, padulong sa kidney, so sa mga blood vessels. So we can measure the cardiac enzymes. Okay? That's for acute tubular necrosis. All right? Very important, dears. Acute tubular necrosis is of course, diba, for hemoglobinuria, myoglobinuria. Because again, your hemoglobin, myoglobin are toxic, no? And these substances can cause necrosis. It can damage the cells sa imuhang tubules. Okay? All right, ayan. Cool. And your ATN, it can also lead to acute renal failure, and it's the most common causes of kidney failure also in hospitalized patients. All right. So again, it may be due to ischemia. So there is a loss of oxygen supply to the kidneys, possible na ay blockage sa blood flow to the kidneys, all right? So that's why we can test for cardiac enzymes, all right? And exposure to toxic agents such as mga nephrotoxic drugs, hemoglobin, myoglobin, which is again toxic to your tubules, and other mga poisons. Okay, all right. Whew. Okay, all right. Sige. But again, the damage can be reversed as long as the impending agent, all right, such as the drug, the medication, or the ischemia is corrected. So if mawala na to siya, pwede na mubalik to normal imuhang function. Okay? All right, so that's for you acute tubular necrosis. And again, take note, di ba? With patients with acute renal failure and then ay acute tubular necrosis, kung sa characteristic odor sa imuhang ihi, it's odorless. So it's very important. It's very scary then. It's not normal to have an odorless urine. So pasalamat ra ka, nagpagpangihi ni mo, after a while, nanimaho siya. So mag-thank you Lord ra ka because your tubules are working properly. Okay? Wala kay acute tubular necrosis. Because if odorless ang ihi, it means there is acute tubular necrosis, especially seen in patients with acute renal failure. All right, okay. That's for acute tubular necrosis. Next, of course, you have Fanconi syndrome. As we have mentioned, inherited siya in association with cystinosis or heart-knock disease and may be acquired to exposure to toxic agents. So again, the problem here is there's defective tubular reabsorption. So example, mga glucose, phosphate, no, hindi na siya reabsorb, or cysteine also. So that's why primary UA results, there may be glucosuria and cysteine crystals. Other significant tests, of course, the detection of mga electrolytes nato and amino acid chromatography, right? Especially for cysteine, no? Because there's defective tubular reabsorption, no, for Fanconi syndrome. So it's inherited genetic disorder. Next, you have uromodulin-associated kidney disease or UKD. So it's still inherited, no? There is a mutation sa gene, okay, in the production of the uromodulin, okay? And because of that, the mutation also releases or also results to the increased production of uric acid. Okay, so na 2-in-1 siya, no? Ni-mutate ang gene or naguba ang gene, defective ang gene, what happens is there's a problem in the production of uromodulin by the RTEs, and aside from that, it led to the increase in the production of uric acid. So therefore, patients with UKD may have gout also and mga uric acid crystals. All right. Now, normal uromodulin is replaced by abnormal forms that can damage your RTE cells. Because again, there's a defect in the gene that produces the normal uromodulin. So, ma-produce kay mga abnormal forms that can damage the RTE cells. Okay, so for clinical course, continual monitoring of renal function for progression to renal failure and possible kidney transplantation. So, it can progress to kidney failure. UA results, of course, RTE cells and hyperuricemia. So, other significant tests, of course, uric acid levels. Okay, because again, di ba, the mutation na 2-in-1 lagi siya. Naguba ang gene that leads is included or that is involved in the production of normal uromodulin, and aside from that, that same gene also leads to the increased production of uric acid. Okay, all right, sige, that's for UKD. No, next you have renal glucosuria. Of course, the presence of glucose in your urine, even if the blood glucose levels is normal in the body. All right, so this is usually a benign disorder, okay, and there is a defective tubular reabsorption of glucose. Or in some cases, such as pregnancy daw, in pregnancy, mo-lower ang renal threshold sa imuhang glucose sa imuhang kidneys. So even if normal imuhang blood glucose levels sa blood, even if normal ang blood glucose levels, mo-appear gyapon siya sa ihi because there's a lowering of the renal threshold sa mga pregnant patients. Okay? All right. So, of course, primary UA results, glucosuria, and of course, other significant tests, renal, blood glucose. All right. And of course, DI, we mentioned that diabetes insipidus, of course, could be neurogenic, nephrogenic. Na-mention na nato. Neurogenic DI, of course, there is a problem in the production by the hypothalamus of ADH. And nephrogenic, ang tubules mismo ang problema. No, the receptors will not react or it will not identify or it will not bind with ADH. All right, so there is continuous loss of water. Okay, so therefore requires supportive therapy to prevent dehydration. So UA results, of course, low specific gravity, kay dilute kay mong ihi, sige lang pangihi, all right, and polyuria. And of course, for additional testing, you have ADH. So we mentioned that already sa initial lectures nato. Ito na na-differentiate. Okay, all right. And here is from Branzel-Deers, the different proximal tubular and renal and distal tubular. So Please read na lang. Ayan. So, unsay mga impaired ability. So, again, majority are impaired reabsorption or secretion bangani, alright, of different substances. It can also be multiple defects, pwedeng inherited, metabolic, alright. And for distal tubular, still the same, impaired ability to reabsorb or secrete or retain possible na mga mga substances. Okay? All right. So that's for distal tubular dysfunctions and the proximal tubular dysfunctions. Okay. All right. And for the last, ano ba day? Dili pa day last. You have the next group, your interstitial disorders. So for when you say interstitial, it refers to the renal interstitium, and the interstitium is the space, no? That between the renal tubules and the mga kapad, mga other tubules. All right. And disorders affecting the interstitium, kani mga spaces here, ayan, can also affect the tubules. That's why it's also known as tubulo-interstitial diseases. All right. And most of these infections involve infections and inflammation. All right. So most common renal disease is UTI, ayan, urinary tract infection. It's an interstitial disorder, meaning kani sila tanan yun affected ang mga spaces and tubules. All right. Ayan. So most common renal infect or renal disease dito sa tanan-tanan layers is of course UTI. All right. So infection may involve the lower, no, urethra, bladder, which is known as the lower UTI, or again upper UTI. It may include na the kidneys, the pelvis, the tubules, and the interstitium. And the most frequently encountered is cystitis of bladder, all right, lower UTI, and can progress to a serious upper UTI if untreated. Now, that is known as the ascending UTI. Ang bacteria gikan sa bladder, musaka siya padung sa kidneys. That's why it's known as ascending. And that's the most common type of UTI na possible na mga complication. Alright? So, imuhang normal na UTI, bahalag lower UTI na siya, dears. Again, you have to make sure na matambalan siya. Okay? Pwede siyang mo-progress, ang bacteria pwede siyang musaka, padulong sa imuhang kidneys, which can cause more severe na damages and infection and symptoms. Okay? Alright. So we now look at the different diseases. Ayan. So you have again cystitis. No, what is cystitis? The inflammation of the cyst. Charot. Again, infection of the bladder, inflammation of the bladder, ascending bacterial infection of the bladder. Or again, this is the lower UTI. So of course, clinical course, acute onset, sige kag pangihi, no? Increased urge or increased frequency of urination and burning when there is urination. And of course, matabalan siya with antibiotics. For microscopic results or UA results, of course, there are a lot of WBCs, bacteriuria, of course. There could be hematuria, and mild proteinuria. But again, take note, na-mention na natin sa microscopic exam, there is no cast. Ano ganito? Because again, it's lower UTI. So bladders are affected. So therefore, casts are not formed. Diba? Remember, casts are formed within the tubules of the kidneys. So therefore, lower UTI man, wala man na-apel ang mga kidney tubules, ang kidneys mismo. So therefore, wala kayo makita ang casts sa ihin. Naku, take note of that. Alright? And of course, other significant tests, urine culture. Okay? Next, we go now to your upper UTI, your acute pyelonephritis. So nasa pangalan na. So it's infection of the renal tubules and interstitium mismo, related to interference of urine flow to the bladder, reflux of urine from the bladder, which is your also known as vesico-urethral reflux, and untreated cystitis. So muna siya mga possible causes, no? It could be again interference of urine flow to the bladder, or possible po na hematogenous na bacteremia na nabot sa kidneys. Ayan, so it can lead to infection there. Gikan na sa blood, no? Bacteremia or sepsis nabot sa kidneys. Ayan. And vesico-urethral reflux. So na problema na instead na padung sa bladder, nisaka siya balik sa ureter. Okay? Ayan. Or na siya sa bladder, nisaka siya balik padulong sa kidney. So that's vesico-urethral reflux. That's a defect in the muscles and in the bladder, and untreated cystitis. Ayun. So ang lower UTI, wala mo siya gitambalan, nisaka ang bacteria padulong sa imuhang renal pelvis, alright, or sa interstitium and renal tubules. So clinical course, again, acute onset, burning yapon, lower back pain. For primary UA results, again, medyo same sa cystitis, pero ang difference na anay, casts, bacterial casts, WBC casts, bacteria and WBCs na gyapon. So again, as mentioned, basta gani, na na WBC casts, bacterial casts, sa imuhang UA results, press the buzzer. That is acute pyelonephritis. Okay? Because again, kung wala yung mga casts, WBC, bacterial casts magani, then that is cystitis, lower UTI. Pero, if na nagani casts, WBC, bacterial casts, then that indicates bacterial infection in your renal tubules. So therefore, that is acute pyelonephritis. All right? And of course, other significant tests, you have urine culture and blood culture. Because again, as mentioned, pwede siyang bacteremia, gikan sa blood, all right, no? Of course, na nabot siya sa kidneys and dito nag-cause of infection. Next, of course, kung acute pyelonephritis, dili maagapan, it can progress to chronic. So it's recurrent infection of the renal tubules and interstitium, primarily due to structural abnormalities in your urinary tract that affects the flow of urine. All right, so it's usually used in diagnosed in children. It requires correction of the underlying structural defect and may progress to renal failure. So take note for UA results, dears. Same ra gyud sa acute pyelonephritis, the difference lang kay ang cast na pod. Basta gani na-mention nato na naanay waxy broadcast, okay, di ba? It indicates chronicity. So therefore, imuhang results sa case studies, if makakita ka WBC casts, WBCs and bacteria, bacterial casts, pero nanay waxy and broad, then of course, you have to look for chronic pyelonephritis. Pero kung ang given na sa UA results kay WBC casts, alright, bacterial casts, pero walay waxy or broad cast, then that's an acute pyelonephritis. Now, please take note of that, dears. So, asa ta mag-differentiate sa acute and chronic sa casts. Kung sa na type, dapat waxy and broad. And if makita ng waxy or broad cast, it can indicate chronicity. So, therefore, ang disease is chronic. So, pwedeng chronic pyelo or chronic glomerulo, depending on the other UA results. So other significant tests, of course, urine culture, blood culture, and of course, you now add kidney function tests because again, it's chronic, no? So you're expecting the possible na progression to renal failure. So you have to include kidney function tests such as creatinine, no? Your BUN, and of course, creatinine clearance. Okay. And of course, your acute interstitial nephritis. So acute interstitial nephritis, as a pangalan na, it's the reaction, inflammation of your interstitium. Okay. Usually allergic inflammation of the interstitium in response to drugs. Pero the most common cause of acute interstitial nephritis is the rejection of an allograft, kidney allograft, no, or transplanted na kidney. So that's the most common cause of acute interstitial nephritis. Okay, but again, it can also be caused by allergic reaction, no, to medication such as penicillin, no, mga NSAIDs, non-steroidal anti-inflammatory drugs, no, and other mga drugs. Okay, all right. So there is acute onset of renal dysfunction accompanied by a skin rash because again, ay allergies. Ayan. It resolves, of course, following discontinuation of the drug, no, na nag-cause ato. But again, if renal transplant siya, then of course, kailangan na siya further procedures para or painom siya of other drugs para mawala ang reaction to the transplanted kidney. Now, of course, again, for primary UA results, naa siya WBC casts. And of course, sa ito na WBCs, ang increase gani, basta acute interstitial nephritis, you have eosinophils. So, dapat na ang eosinophils. And as you can see, wala siya bacteria. Because we mentioned again that the cause is not bacteria, but rather allergy, no, allergic reaction, rejection of a renal transplant. Okay, so therefore wala bacteria. And this is called sterile leukocyturia. Taas yung WBCs pero wala siya bacteria. That's why it's called sterile leukocyturia. So again, for significant test, eosinophils, urine eosinophils, and of course, BUN, creatinine clearance, of course, to detect or to check kidney function. Okay, because this may progress yapon to renal failure, okay, in the long run. Okay, so that's for the interstitial disorders. So take note at the mga na-mention, dears, ha, mga WBC cast. So take note, basta WBC casts, bacterial casts lang naa, that indicates acute pyelonephritis. Kung naana siya WBC cast, bacterial cast, waxy cast, and broad cast, that is chronic pyelonephritis. If wala yung mga casts, pero naay WBCs, bacteria, then that indicates lower UTI, so it could be cystitis or urethritis ba. But if naay WBC casts, naay WBCs po pero walay bacteria and increased ang eosinophils, then that is acute interstitial nephritis. Alright? So I hope na-get to siya. No? So medyo easy lang due to differentiate. Muna akong ganahan na part. Dili na kayo siya i-differentiate. So you look at the casts yun. You look at the UA results and look at casts. Okay? Kung saan ang mga type of casts ang naa. Okay? Alright, sige. So that's for if na-casts ba or wala po. Ayan. So that's for the interstitial disorders. Okay? Now, for the last type of these disorders, again, you can use a Brunzel. Wala sa inyong notes na akong nasend. But again, ako rin i-post. So it's talking more about on the changes, no, in the blood vessels to the kidneys or blood vessels of the kidneys. Okay? Because again, we mentioned that for kidneys to produce urine, it must have a blood, no? Or blood must be supplied to the kidneys for urine to be formed. Kaya sa may filter sa imuhang kidneys kung walay blood flow. So therefore, if na changes sa mga blood flow because of vascular abnormalities, no? Changes in the vasculature of the kidney, no? Then it can cause also changes or damages to your kidneys. All right. So these are disorders that alter the blood vessels or blood supply to the kidney. All right. So example, atherosclerosis. Ayan. May mga deposition sa intrarenal arteries. So there's a reduction in renal blood flow. Hypertension, polyarteritis nodosa, and eclampsia, diabetes, and amyloidosis also can cause significant changes in the arterioles and glomerular capillaries. No, it can lead to renal ischemia. So there is loss of oxygen supply, no, to your kidneys. Could be of obstructions of blood flow yapon. And hypertension, good years, is the frequent finding in many kidney disorders. All right, when there is a damage or there's a change in the ability of the kidneys to alter the blood pressure. And among the chronic disorders, good years, na dili, mga secondary, no, disorders that can lead to renal disease, diabetes and hypertension yun ang pinaka-common na makakause of complications sa kidneys. All right, so diabetes and hypertension, the two most common chronic disorders that can cause renal disease. Okay, all right, so that's for your vascular disorders. All right, now of course all these diseases, they're all talking about acute, no, na onset, and then followed by chronic onset. Now if these diseases, of course, we mentioned that some of these diseases can progress to a more life-threatening disorder, which is of course your renal failure. All right, now for renal failure, nasa pangalan na, the kidneys again have a decreased overall renal function. All right, so as you can see, there's decrease na in glomerular filtration rate, less than 25 ml per minute. So as you can see, gamay na yung ma-filter. All right, so because of a decrease in your glomerular filtration, then of course, accumulate ang mga substances, especially the non-protein nitrogenous compounds such as your BUN and creatinine. So therefore, there's azotemia. Of course, there's electrolyte imbalance because the kidneys are not able not to balance or to maintain the reabsorption secretion of these electrolytes. There is also a negative renal concentrating ability, so isostenuria, because again, the tubules have lost the ability na to concentrate. So therefore, consistent na lang yung SG, di ba, which is about usually 1.010. So meaning katong plasma filtrate na naa sa imuhang glomerulus, same rapod silang SG sa imong ihi. Alright? Which means wala na gyud ang tubular concentrating ability sa imuhang tubules. Of course, there's proteinuria and renal glycosuria. So mag-release na siya mga substances that are normally absorbed or substances that should not be filtered by the glomerulus. Kaya of course, nawala na yung function. And of course, increase in the telescoped sediment. So, unsay pasabot sa telescoped sediment? Simultaneous appearance of the different microscopic elements of your chronic GN and nephrotic syndrome. So, there's increase in cells and casts of different sizes, different types, in equal numbers. So, that's telescoped sediment. Meaning, naanagidot tanan, di ba? So, when you use a telescope, di ba, you see a lot of stars, the mga planets, inana. So, that's the point, no? Telescoped sediment. Tanang cast cells, all right? Na yung makita, they're all there in equal number of amounts. Okay? Or in equal amounts. Okay? So here's an example. Ayan, as you can see, yung mga cast there, medyo hugaw, no? Hugaw na griyahang urinalysis. Daga na kayo mga sediments. Okay? So medyo maglisod na kag-identify because tanang cast dito, granular, waxy, broad, RBCs ng mga cells, tanan-tanan, WBCs, makita na nimo in equal amounts. Okay? So that's telescoped sediment. Alright? And that indicates again, renal failure. Okay, but again, telescope sediment can also be seen in chronic GN pod, no? So, muna siya point lang, all right? So, there's already the accumulation of different sediments, no, in equal amounts, all right? And usually signifying medyo chronicity or mas intense na damage or pathology. Okay, so of course, your renal failure can be divided into two. You have the acute renal failure, also known as acute kidney injury. Kani siya there is sudden loss, like pakalit lang yun. The sudden loss of the ability of the kidneys to remove waste and concentrate urine without losing electrolytes, which is due to many possible causes. And the most common is ischemic acute tubular necrosis. So there is pakalit. Example, ischemic na ipakalit na blockage sa blood flow. So wala oxygen ang kidneys na ma-receive. So therefore, ma-damage ang tubules such as acute tubular necrosis, which leads na to renal failure. Okay? Naglisod naman ang function, wala na. So, acute renal failure. Okay? So, there is accumulation of urea and of course, other nitrogenous waste products and decreased glomerular filtration rates. And again, what are the causes? Here are the causes. Pwede siyang pre-renal, decreased blood flow, hemorrhage, no? Septicemia. Renal, of course, AGN, ATN, acute tubular, acute pyelo, and acute interstitial. And post-renal, pwedeng renal calculi and tumors. Could lead to mga blockage, no, in the blood flow, mga inana. Alright, so there is sudden onset, pakalit na yun siya. Alright, and as you can see, ang mga causes, usually, makatulad po mga acute, no, in onset, kanang pakalit or, pakalit na mga diseases. And of course, you have chronic, which is progress na, no? Progression na or dugay na gid siya na type of kidney disorder such as chronic GN, and then wala na address. Okay, so of course, ni-produce siya or ni-progress na siya to renal failure. And this progression can occur in 4 stages. Number 1, you have diminished renal reserve, in which ang GFR niya is about 50% of normal na lang. For renal insufficiency, the GFR continues to decline to about 25%. And mo start na azotemia, so mag-accumulate na sugod ang BUN, creatinine. There's also anemia na because the kidneys loses its ability to produce erythropoietin, all right, which is again needed for erythropoiesis, so therefore na anemia. And of course, hypertension begins. No, the kidney loses its ability to regulate blood pressure. The third is renal failure na yun. GFR is less than 20. It can lead na to metabolic acidosis. The kidneys loses its ability to regulate concentration and solute, volume, concentration, hyperkalemia, edema also develop. And ang pinaka-last yun is ESRD, end-stage renal disease. So here, GFR is less than 5 na yun. Glomerular scarring and reduction of renal capillaries, tubular atrophy and fibrosis, loss na of kidney mass, damage na yun majority of the kidneys, wala na yun mo work, and hindi na kailangan of dialysis or transplantation for survival. Alright? So katong mga essential na renal functions, critical renal functions are lost. So wala na yun. Okay? So for you to survive na lang yun is mag-dialysis na lang ka. Okay? Or renal transplantation. Okay? Muhang majority of your kidneys, guba na yun. Wala na yun. Wala na yung filter. Bisag gamay na nephrons, wala na yun. Okay? Alright. So that's the stages of chronic renal failure. Okay? Alright. Or chronic kidney disease, CKD. Ayan. Alright. So that's for your renal failure. Okay? So again, kato ato mga kidney disorders, especially glomerular, no? And mga tubular, basta gani, even mga interstitial bacterial infection, again, we have to address it as soon as possible to prevent, no, the complications, severe complications that may happen if ato siyang ipadugay. Okay? Alright. Because again, it can lead to renal failure. Alright? Okay, so that's for renal failure. Okay? And for the last types of diseases, alright, for the kidneys is of course your renal lithiasis or renal calculi, or again, in layman's term, kidney stones. Alright? Now, renal calculi, kidney stones, asa siya ma-form not only in the kidneys and the pelvis of the kidneys and calyces, but it can also form in the bladder, in the ureters. Ayan, take note, no? Basta pa mo which of the following, or asa man ma-form mga kidney stones. Again, bisagasa, not only in the kidneys mismo, like calyces or the pelvis, but also in the ureters and bladder. Alright? Now, renal lithiasis or kidney stones is the most common cause of course, urinary tract obstruction. Alright? Upper renal stones are more common in Western industrialized countries, whereas bladder stones are uncommon. Okay, so I think natabunan in countries na nagdapita sa new notes there, so pasensya. Okay, now conditions favoring the formation of renal calculi is actually the same for crystals. Number 1 is of course pH, no? Depending siya on the crystals that will form your kidney stones. So of course, we mentioned sa crystals, di ba, na ay mo form of acidic, na mo form of alkaline pH, alright? Number 2 is, of course, chemical concentration. If these solutes are in high concentrations in your blood, in your filtrate, of course, they will precipitate out of the solution or out of the filtrate and become crystals. And once they become crystals, they will aggregate together to form the kidney stones or the calculi. And of course, you have urinary stasis. Of course, if there's a prolonged obstruction, prolonged retention of the filtrate or the urine that contains a lot of the solutes, all right, so it will give them time to aggregate. It will give them time to precipitate more. That's why mas conducive for the production of renal calculi or kidney stones. And the primary UA finding there is, of course, microscopic hematuria. Please take note of that. No? So, imuhang urine, pag pangihi sa patient na possible na kidney stones, medyo clear pa lang. Pero paglantaw nimo sa imuhang microscopic, ayan, na kayo makakita ang RBCs. That's initially the first sign or primary UA finding yun. Because again, remember that kidney stones are hard, no? They can be hard, all right? And pagpas sa kidneys or pagpas sa mga tubules sa sulod sa kidneys, it may damage or it may irritate the lining of the kidneys, all right, or of the tubules. That's why it can lead to bleeding. And usually, ang initially pag if gamay pa lang ang mga stones, possible na gamay pa lang na number of RBCs ang makita. That's why dili pa siya gross hematuria or macroscopic na kanadyong red na ihi makita lang siya sa microscope. Alright? And once gani nasa ER, mag-doctor na mo or sa case studies mo gani, ang ibutan dito kay patient presented with back pain, nako ayan, back pain, pain during urination, and microscopic hematuria, nako, press the buzzer, that is kidney stones. Alright? Because back pain, of course, sakit na siya kay nag-block good ang kidney stones sa imong tubules. Alright? So sakit. So pag-agi sa urine, dili makaagi ang urine. So possible na maka-result to pain. Alright? Kay ilang i-try og move ang kidney stones kay para mo gawas, di ba? Pero dili man sa mga dako. So that's na pain. Pain during urination, alright? And back pain. There is a lower back pain. And of course, pag UA results, paglantaw sa microscopic na RBCs na nakitaan, press the buzzer. That is kidney stones. True enough, parang nice student, di na mo mention asa. Pero basta, I think I was last year, manata to. Na-student ako siya first year, no? Karon kay third year na siya. Oh my God. So, natin time, pandemic to siya, second year siya, and then, akong gisandan sa yung UA results, alright? Tapos, akong giinan, anak ko, sabi mong other symptoms, tears, anak ko, anak siya na, sir, kanang sakit akong likod, pagpangihi, anak ko na, anak ko, OMG, I have already, nanak ko yung hunch, no? Nado siya lower back pain, no? Sakit daw yung likod. And magsakit daw po pag-urinate. Then, paglantaw na ako sa results, ayan, akong gisandan sa yung UA, ayan, iyakang results ato, remember kung physical niya kay amber, so medyo dark, concentrated. Tapos, paglantaw na ako, iyakang clarity kay turbid, ano ko, oh my gosh, very, ano na talaga, no? Very evident. Paglantaw sa RBCs, ayun, daghan kaayo. So, paglantaw na ako ako siyang gingnan na, dears, I think na kay kidney stones, no? Ako siyang gingnan. Pero of course, ano na po ko na, of course, kita medtex, we cannot diagnose. So, for us to be sure, i-present lang sa imuhang doctor, imuhang results. So, pag inato, pangumusta na ako niya from some other time, kay anak ko na, so dears, kamusta man ka? Then ano siya na, sir, chaptog yun, na ako'y kidney stones. So, diba? So, we're applying what we already know, no? So, inana, no? So, you have to coordinate with patient history, patient symptoms, and of course, urinalysis results. So, again, ato makita, microscopic hematuria most of the time, pero katong sa akong gihatag na example, na medyo na-diagnose na ko siya, okay, is ano na to, gross hematuria na to siya, kay daghan na kayo ni turbid na iyahang ihi, okay? Alright, tapos daghan pong RBCs na kita, okay? So, basta medtech student to siya, actually medtech student na karon, okay? So, baka, is this my calling na to proceed to medicine? Tsaka lang. Yeah. Tsaka, no, it's not. Charot. Okay, anyway. So, ayun, nalipay na po ko na, shucks, medyo na-apply din ako siya. And it really happens in real life, no? So, kana itong mga ma-learning diri dears, bahalag mo rin makatik mo na, shucks, asa man ako ni ma-apply? No? It will be applied. Yes, ma-apply din siya. Especially when you have family members, friends na mag-mo-ask kung opinion mo once you become RMTs na good. Or even now, di ba? I think naka-experience na mo na you're still students pero some of your family members will ask na, huy, pa-interpret ko na lab results or like kung say pasabot ani. You can share your insights there but always emphasize na again, kailangan na siya ipakita sa mong doctor because the final say is your doctor. Okay? Sila yun ang makadiagnose kita, igurat ang process, makakita sa results, we can have already our hunches and mga initial ideas pero again, the final call, ayan, the final call will be made by the doctor. Okay? And dili sa medtech. Alright? So, you can share your ideas sa mga possible causes, but always emphasize lang yun na in the end, imuhang doctor gyapon ang masunod and siya lagi makadiagnose ana. So, ipakita rin mong lab results, auntie, uncle, friend, beshi, yot sa imuhang doctor. Okay? Alright. Ina na to ang mga disclaimer. Okay? When natin mga kailan na family members or friends na magpa-interpret og lab results. Yes, very common na siya, dears. No? Ikapilan ako. I'm sure inyo naka-experience na mo and if wala pa sa future na yun na. Okay? Alright, so that's for renal lithiasis. Again, primary UA finding is microscopic hematuria. Because again, remember that kidney stones, they can irritate the lining of the tubules, no, pag-pass nila, pag-try og ihi or pag-try og remove, so therefore it can produce RBCs. Alright? Okay, so as you can see, ang condition, same ragid siya with crystal formation sa itong microscopic. So therefore, since we already know that, no, so we can modify a lot of changes atong diet, especially sa diet, because majority of the causes of kidney stones are from our diet. No, some are inherited, pero majority good are from diet. So knowing na, okay, stone former ko, like ikaw, you are really prone to forming kidney stones, so you have to modify your diet. So less na limong salt, sige na kag inom og tubig, of course, hydration, change your pH sa ihi, okay? So magkaon na lang kag mga alkaline para imong urine kay alkaline to prevent the precipitation of these crystals, all right? And of course, dili ka magpugong ihi, ayan, and magsikag inom of water, okay? Because again, another condition is of course chemical concentration, di ba? If you are dehydrated, so therefore your solutes are really concentrated, so therefore it can really induce the formation of crystals and like eventually the formation of calculi. All right, okay, so we go now to the methods for the analysis of calculi. You have, of course, the optical crystallography, radiographic diffraction, infrared spectroscopy, and electron beam analysis and mass spectroscopy. So mga high-end siya na techniques, dears, okay? So usually in routine laboratory, wala akong ka-experience na i-identify ang kidney stone. Wala akong ka-experience yun. That's in my two hospitals. Pero in some hospitals, I think they will they they offer no these services, pero murag wala sila ani na other methods, mga high end. Pero some laboratories na high end, of course, they have this. All right, now for composition of renal calculi, of course, 80% or the most common cause of your renal calculi is of course calcium oxalate, which is a mixture of course oxalate and calcium phosphate. So therefore, as I mentioned, katong sa vitamin C pa lang, no, so if maglaklak mo vitamin C, dears, take note, be careful, no, inom jud og daghang tubig because again, too much ascorbic acid, of course, will be metabolized normally, of course, to oxalate. So if daghan kang ascorbic acid, so daghan kang oxalate na ma-produce. So it can combine with calcium sa imuhang blood, and in the urine or in kidneys, it can form renal calculi, all right? Which is CaOx, and the most common cause of your renal calculi. 3 to 10% each, of course, calcium phosphate, the magnesium ammonium phosphate or struvite, and uric acid, all right? And 1 to 2% pinaka-rare or gamay lang yun is the cystine crystals or cystine stones. So this is from Brenzel. As you can see, medyo gamay ra gyud ang cystine. Pinaka-common is still calcium oxalate. So usually calcium gyud siya and partnered with other organic substances such as oxalate, phosphate, and others. Pwedeng calcium sulfate, may nana. So kato mga crystals, no? Possible gyud sila mo form og not all naman, pero some of them again can form renal calculi. All right. So we now go to the description or causes of the various calculi composition. So for calcium composition, as you can see, it's more on intake Japon, all right? Or example RTA. So the renal tubular acidosis, of course, the inability to release mga H plus ions. So therefore, what happens to concentrate, pwede siyang mo reabsorb more calcium, okay? So therefore, muna siya mo increase mo calcium. For CaOx, as you can see, oxaluria, ayan, increase imuhang intake of mga oxalic acid na mga foods or ascorbic acid rich na mga foods. Or again, di ba natin bacteria that again, iyang main function is to degrade oxalate, your Oxalobacter formigenes. So if wala ka na bacteria, you have oxaluria or hyperoxalemia, oxaluria. Incomplete catabolism of carbohydrates, isohydria. When you say isohydria, dears, there is a constant pH na lang yun, no? So kung isostenuria kay constant ang SG, isohydria is constant pH, urinary pH. Bahalag kung pila ka sample. So if acidic, siging acidic imong ihip, no? Constant yun acidic, such as 5.5 to 6, it can produce CaOx. Excessive glycogen breakdown and primary hyperthyroidism. Mga breakdown products, or excessive metabolism can lead to more oxalic acid, which can lead to CaOx. For calcium phosphate, alkaline infection, of course, versus the alkaline urine. Same, magnesium ammonium phosphate hexahydrate, presence of urea-splitting bacteria, especially Proteus, okay, Proteus mirabilis, no? Also, Pseudomonas and Enterococci, according to Brenzel, kaya maproduce sila og ilang i-convert ng urea, no? So, mga urea-splitting bacteria. Uric acid and urate, of course, gout, increase imuhang turnover of cells such as polycythemia, leukemia, lymphoma. Acid isohydria, same sa CaOx, siging ga-acidic imong pH sa ihi. And of course, conditions associated with rapid protein catabolism. So sige produce of purine, no? All right. And of course, cystine, cystinuria, cystinosis natong gi-mention, of course, pero mas common sa cystinuria ang renal calculi. So inherited defects, all right, aminoaciduria and renal tubular acidosis po na mga symptoms possible. All right. Okay, those are the possible causes. Now we go now to the values of pH. Again, kinsa itong mga acidic na pH, mo precipitate sila, of course, uric acid, cystine or xanthine na calculi. pH 5 to 6, you have CaOx and apatite. And for pH 7, greater than 7, alkaline na, of course, the struvite or calcium phosphate. So same regular siya. It follows with the crystals na itong discussion. So they are pH dependent. Okay? So kung kinsa itong mga acidic na crystals, sila po na mo-precipitate in acidic pH to form the renal calculi. And katong mga alkaline crystals, alright, sila po na mo-precipitate in alkaline pH to form the renal calculi. Now, we go na to physical characteristics. Ayan, very important dears. Okay, so Ka-ox sa appearance, major constituent, again, renal calculi, very hard, dark in color with rough surface. So, medyo dark in color and medyo rough, lang tawon. Uric acid, urate, again, pwede siyang hyperuricemia, taas kang uric acid levels, or katong UKD na disease. Pwede siyang makakause og increased uric acid concentration. Actually, ako po, taas kong uric acid. Akong last lab, pa-check sa akong serum concentration sa uric acid, kita siya dears as in. Ganaan mong kumukhaon og, charot. Ganaan kumukhaon og mga like, sisig ka na mga internal organs, no? Like sisig, mga paklay, and kanas lahat ang sila og uric acid. So I have to, and also meat, actually, taas mo ng uric acid and all, and mga beer, charot. So I have to be careful. Okay, ayan. So, muna siya akong last labs, taas ko uric acid. Shucks! Oh my gosh. Okay, so ayan. So very prone na to stone formation. Alright? Now for cystine, again, hereditary disorders, cystinuria, especially cystinuria. Yellow, brown, greasy, iyang appearance, mara siyang oily. Ayan. Mara siyang soup. Ayan. Old soup and the least common calculi. Phosphate calculi, pale and friable, pwede siyang mabungkag agad-agad. Alright? And for triple phosphate, again, usually from UTI caused by urea splitting bacteria such as Proteus. Ang ilahang appearance sa stone kay staghorn. Mura siyang antler sa deer. So, dagko siya. Alright? So, later na picture. Now, rare calculi, mga sulfonamide, no? So, such as kanang pag-intake nimo, no? O mga drugs and sulfonamides. Silica, ingestion of silica over a long period of time. Triamterene kay insoluble na mga diuretics, so tambal gyapon. Mustard colored, iyahang stones. Adenine calculi, inherited gyapon na enzyme deficiency and hyperuricemia. Katuni siyang AGPRT, katong 2,8-hydroxyadenine crystals na ito na-mention, which can be mistaken as leucine. So, pwede siyang mo-form o calculi po. And of course, xanthine calculi. Xanthine. No? Xanthone plus. Charot. Xanthine. Alright? It can associated siya with genetic disorder that has or that lacks the enzyme xanthine oxidase. Diba? Xanthine oxidase is included in purine metabolism na enzyme. Okay? So, if wala na siya, pwede siyang mo-precipitate. Okay? And form as a calculi. So here are some pictures. As you can see, ang Ka-ox deers, it's dark, no, rough in surface. Uric acid, ayan. Cystine, wala siya greasy, wala siya katong candy bitaw na kanong sa una na ano ra. Okay. Then you have calcium phosphate, ayan, pale and friable, meaning medyo brittle siya. Okay. Xanthine calculi, medyo reddish brown. Wala siya nakukay siya deers. Wala siya kahoy, charot. And this is your staghorn. As you can see, ang staghorn, wala siya og antler sa deers, no? Ayan, wala siya katong horns, no? Antlers sa deer, alright? So ano siya yung appearance? Because again, ni-involve na siya sa different calyces and pelvis sa imuhang kidney. Ni-extend na siya, no? Iyahang stone can take into the shape of the pelvis and calyces sa kidneys. That's why, iyahang appearance, mura siya o deer. No, mura siya antlers sa deer. And this is known as staghorn, okay? And again, ang sa crystal, ang nag-cause ani, magnesium ammonium phosphate, your struvite, okay? Staghorn, okay? Ayan. Ngano ganito? Because again, iyahang i-take into the shape, ni-extend na siya from the different calyces, no, of your kidneys. Okay? Ayan, sige. That's for staghorn. Alright. Now, for natural inhibitors of calculi formation, another reason daw why you are possibly a stone former, it's because you lack, no, wala ka ani mga natural inhibitors of calculi formation, such as nephrocalcin, osteopontin, citrate, tamporsal protein, uromodulin, chondroitin sulfate, calgranulin, bicunin, prothrombin F1 fragment, heparan sulfate, pyrophosphate, and CD59. So, ako siyang include nila dears, kaya gikan siya sa Brunzel. So, what if he asks a question, he asks in your exam, sa board exam ba, which of the following is an inhibitor of calculi formation? So, press the buzzer na. So, take note of that. Alright? So, as you can see, ang uromodulin deer kay pwede, no? So, that's another reason siguro why UKD, uromodulin kidney disease, kay makakause siya og increase in calculi. Kaya wala uromodulin, guba ang uromodulin. So, possible na wala mo inhibit sa calculi formation. Interesting. Okay, karon po ka-realize ano. Alright, okay. Now for analysis of renal calculi, katong mga chemical tests, no, or mga pwedeng routine or chemical test to identify your renal calculi. So you first wipe the stone and then describe it in terms of the size, the shape, color, and hardness. And number 2, you powder the stone and dissolve it in HCl. If na foaming na ma-produce, then the composition is made up of carbonate. Katong acid extract or liquid, imo siyang adan og sodium cyanide and sodium nitroprusside. If na magenta color, then that is caused by cysteine. If acid extract, additionally mo ammonium molybdate and ferrous ammonium sulfate and sulfuric acid. If there's a blue color, then that is phosphate. If ang acid extract, katong na-dissolve nimo ang powder na stone with HCl, then adan nimo NaOH and para-nitrobenzene azoresorcinol and leads to a blue precipitate, then that is caused by magnesium. If acid extract plus NaOH plus clasein and KOH, there's pale yellow color that is caused by calcium. Acid extract plus NaOH plus mercuric iodide plus potassium iodide, there's an orange-brown color that is caused, then the composition is ammonium. Acid extract plus NaOH plus cuproin plus acetic acid, there's HAC, plus copper sulfate, yellow-orange color, it is due to, or the composition is uric acid. And acid extract plus manganese oxide, black sediment which settles and bubbles, which appear from the bottom of the tube, then the composition is oxalate. Okay, so which are my expected results using different chemicals. So I think in routine laboratories na mo identify sa stones, siguro sa histopath niya na section, usually inani ilahang procedure. Okay, so I'm not really sure kung sa mga procedures, ang main procedure good, pero this is from my review notes sa Lemar. So I'm not sure kung asa po nakuha ni siya na resource, nag-book na, wala akong kabalong sa na-book, pero base mga older books sa urinalysis, no? So take note of that, dears. Baka lumabas pa rin, no? So take note kung sa mga reagents and sa mga colors, alright, na ma-produce and kinsa ang possible composition na nag-produce ani na color, alright? And for each cation, ayan, there is an anion na involved, alright? And ammonium should accompany magnesium. So if na magnesium, na dapat ammonium po. So if positive siya sa magnesium sa imong pag-test, so possible po na siya ammonium na dala, okay? Because ammonium should accompany magnesium. And for each cation such as calcium or whatever, ayang anion, of course, na siya partner, oxalate, phosphate ba, or carbonate. Okay, so I'm not really sure sa entire procedure, dears, ha? Basin you examine, baka you make aliquots of your, di ba, imo mang i-dissolve ang powder sa HCl. So, i-dissolve mo ang stone, imo siya i-powderize, and then butan mo siya HCl. And maybe katong liquid, imo siyang i-divide into different test tubes, and then you perform all of that. I'm not sure lang ha, kung sa your procedure, pero that's the reagents na needed. Okay? Alright, so that's for the analysis of renal calculi in terms of their composition. Alright? And for the treatment and prevention, of course, for prevention, take note, dears, again, number one, increase fluid intake. Because again, chemical concentration, one of the factors that can precipitate or one of the factors involved in the production of renal calculi. All right. So the increase in fluid intake, of course, it will dissolve the solutes para kaya siya concentrated. Of course, number two, modify diet, because again, majority of these solutes come from our diet. So if kabalo na ka na stone former ka, then you have to modify your diet. Okay, so kailangan na less na kag-salt, sige na kayo ng tubig, na. Alright? And of course, oral medications such as kato mga medications na makakos o calculi, sulfonamides, and also mga you can take also diuretics or whatever the medications. And of course, eliminating the causative agent, especially UTI, no? Those that cause UTI, mga urea splitting bacteria, to prevent mga staghorn calculi. Alright? Now, for treatment, of course, number one, if gamay na ang stone, pwede na siyang, imo siyang i-wait ra ka na maihi nimo siya. Okay? So, si Kuya JJ, di ba? Si Sir JJ, yes. Muna yung nahitabo niya recent, last month, I think. Na siya gamay na kidney stone, and ilang i-wait, no? Na maihi niya. Pero naka-experience ka mo siya of pain, no? Lower back pain. Sorry, Kuya J. Sorry, Sir J. Na-mention ako siya. But yes, manifestations, hato ang lesson, no? Aside from that, if medyo dako na good, you can perform, or the surgeon can perform an extracorporeal shockwave lithotripsy. Ayan. So, nasa pangalan na litho, so stone tripsy, bungkagod, no? So, ang buhaton ani is of course the patient, ayan, ay shockwaves, ayan, sound waves, ayan, na focus during dapita sa area kung asa ang kidney stones, and the shockwaves will of course break, no, the stones into manageable pieces para maihi lang siya. All right? Now if medyo dako gyud ang stone, the surgeon can also perform cytoscopy, ayan, pares ani, if the stone is located in the ureter or sa bladder lang. All right? So what happens is mo insert siya og machine, all right, kani siya na naay camera, cytoscope, and then rag naay kaning basket iniyang bungkagon ang stone. And of course, if dako na gyud ang stone, di na gyud kaya ani, of course, you can perform percutaneous nephrolithotomy. Ayan, pares ani. Okay? Percutaneous nephrolithotomy, ayan. if your shockwave lithotripsy is unsuccessful. So what happens is, insert tayo diri sa skin o parang kaning machine, and then wala ang surgeon, and of course yung bungkago ng kidney stone dito sa sulod. Alright, sa mo tayo ko again, bungkago ng kidney stones to manageable pieces para yun maihi lang siya, makaya na ma-pass through lang siya sa imuhang urethra and maihi lang siya nimo. Alright, pero if dako na gyud dili pa kaya ani, so pwede na siyang open surgery na gyud, no? Kuha na gyud mismo ang stone from the kidneys. Samot type mga staghorn calculi siguro, pag itong madagko na gyud na kidney stones. Alright, so that's for your renal calculi. Alright, and that's the end also, dears, of our discussion in the renal disease. Ayan, so medyo marami tayong na-discuss. Okay, although again, walay dili gyud siya separate na parameters sa inyong compre, ha. So I still hope na malantaw niyo ni, okay? And you still have the notes in naman, so you can study that. All right, so if you have any question, dears, ayan, you may ask me, okay? you know where to reach me, okay? And I'll try my best to answer. So atong bottom line here, dears, is of course take care of your kidneys, okay? Dili na name magkasakit sa kidneys, okay? Because it's one of the major organs and most important organs yun nato. So take care of them very well. Hydrate well. Iwas-iwasan ang pag shots. So ako rin pala. And yeah, take care of your kidneys, okay? You don't know you don't know when you will need the kidneys in terms of kailangan mo siya ibenta. Para sa BTS concert. Tsaka lang. Basta ang bottom line is take care of your kidneys, okay? Take care of the kidneys. If you feel like nakay changes in your urine, nakay nakita mo abnormalities, then of course have yourself checked up, no, by your doctor. Urinalysis, of course, your medtechs, you already know this. Kung saan ay possible causes, o possible implications aning mga urinalysis results. So of course, it's imperative na dili ka magpaduay-dugay if magpa-check. Samot na kay problema sa kidneys. Not only you, but of course the family and the people around you, mga friends nimo, no. If nasa mga mabati na murag makaingon ka na related sa kidneys, of course, convince them to have themselves checked out by their doctor. Okay, so para dili good ma-progress to a different or to a more serious form. All right, or a more severe complication of your renal disease. All right, so here again are all your renal diseases. Again, there could be a lot pa na wala na mention here. Okay, pero for our class lang, so majority kayo from Strategy and from the books. Other books sa urinalysis, no? So, yeah, so that's all for renal disease. I hope na gets lang, dears, and medyo klaro lang, no? If you have any questions, again, feel free to chat me or email or wherever kabulin mo as ako ma-contact, all right? And I'll see you at our next recorded or live session. Thank you so much for watching. Have a great day. Keep safe and God bless.